brachial plexus, but that doesn't mean it has to be yours. But it's just mine. So remember that we have the trunks to the divisions to the chords. So your upper trunk is C5, C6, your middle trunk is C7, your lower trunk is C8, T1. Didn't y'all do this in Bill's class last year in intro to PT or something? Did that help you? Yeah. Y'all still have them or?
Yeah.
Yeah, I'll do somewhere down next to my car.
Yeah, well anyway.
My girls
that's
do
what
that.
I was thinking, y'all did that. And then you have your anterior division and your posterior division. And on this particular picture, the part with all the lines in it is your posterior division. And then the clear through is your anterior division. And then it divides into chords. And so you've got your lateral chord, you've got your posterior chord, and then you've got your median chord.
We can't see that because it's just a glare, but what do you call
You
it?
have these.
Yeah, what do you call an interior, like the?
Anterior is the divisions, and it's the white that's clear, and then the posterior is the line
Oh, okay,
part.
I'm seeing, okay.
So your anterior division turns into the lateral chord and the medial chord. Your posterior division turns into the posterior chord. So posterior stays pretty much. And normally posterior chord does your extensors. Your anterior chord and the medial chord does the other. Flexors, musculoskeletal, those go up. Pardon? Good. Good. Any questions on how that all comes out? Because we're fixing to go into the nerves. Yes, it's mainly extensors. Your triceps come off of that. Yeah. Okay, so what we're going to do is I want you to have this sheet out. You can't see this at all? You don't see this at all?
Yeah, we kind of did.
You have this sheet, so grab it, and then you're going to want to do this one. Pull that out so you can look at that, because we're going to pull all these together and let you find them on this. And then as we get into the nerves that go all the way down the arm, then I actually have some pictures of those that come out of the old book. Your new book pictures, in my opinion, are better. So if you'll go in there and just look how those nerves come down your arm, it'll be very helpful. What I want you to do on this sheet is mark out the levator scapulae, because that's actually in the cervical plexus, so just mark it out. Because y'all know all about it already.
You don't have any more of those, do you? I don't know if I have that.
I think that's some more of those. Anybody's really able to find them?
Did you get extra for these? I want one.
You have
I
it?
was gonna keep it for a second.
That's your, the extras, Jess?
No, I need one. She passed it on, they can give me one.
It's always somebody else's fault.
See, you sent by me, I would say.
That's what I was thinking.
Oh.
Two Steve.
Okay.
At least you got it and got it for you. Such a sneaky
It's
leopard.
full of my own beer.
Prowler through class.
You have to go to Epic class. You make stars.
Is that your Halloween
Stop.
costume? Is that your Halloween costume?
No, it's a I love leopard. It's none of y'all's business. Shut up.
Okay, so the nerve we're going to start with is the dorsal scapular nerve, and that's the rhomboid muscle. You can see how it comes off of, what does it come off of? C5, or the upper trunk, but mainly C5. So it's a C5 muscle. Comes off right at the, pretty close to the spinal cord. Your long thoracic is C5, C6, C7, and as you can see, it comes down and goes right next to the spinal cord, and that innervates the serratus anterior.
Where's the one, this little one's coming off?
Pardon?
Where does it show it coming off the,
The dorsal
Picture.
scapular or the long thoracic?
I'm looking for the long thoracic.
It's right next to the spinal cord going
okay.
down.
Okay.
So that's your long thoracic. Functionally, you see that come in at about C7, is what I see. So you do normally have your serratus anterior C7. Maybe not all of it. The next one that comes off is your suprascapular nerve, and it's considered off of the C5, C6, so it's off of the upper trunk. Here's your suprascapular nerve, and it does the supraspinatus and the infraspinatus. What does the infraspinatus do? External rotation. What does the supraspinatus do? It's an initiator of abduction. Remember that it doesn't, what's your main abductor? Deltoid. So it initiates that. If you don't have a deltoid, they can do about this, because I've seen it.
Okay.
So it's an initiation of abductor.
What would they do without the,
It also stabilizes the rotator cuff.
what would they do without the suprascapular? Would you notice that much?
You would notice a weakness in the rotator cuff.
That's what I mean.
Yeah.
Besides that.
Yeah. Well, and you'd lose infraspinatus, which is your major external rotator.
Okay.
So that would be a major deal.
Would
That
you
would be
still,
mainly what you would,
with your teres minor, would you still have that action, or would you?
teres minor is a pretty small muscle. You would have a little bit, but you wouldn't have the major. It certainly wouldn't be real strong. I'm not sure that it would even be against gravity, is where that sits. Okay, I believe on your muscle card, your pec major and pec minor says anterior thoracic, is that correct? What did your muscle card say on your pec major and minor, do you remember?
Lateral medial pectoral.
Oh, okay,
All right,
okay, so that's what
Bill's
y'all
book
had,
said.
okay.
Study.
Well, your pec major is C5, 6, and 7, and here's your lateral pectoral coming off of the lateral cord. Your medial pectoral pretty well comes off of, I would say, the medial cord. So you can see they did that for you. Lateral pectoral, lateral cord, medial pectoral, medial cord. I'm sorry here.
I thought it said for the major that it did it was the lateral and medial.
That's what I'm thinking.
I want y'all to do it like this sheet.
Okay.
That's fine.
That was the only
It's not gonna be
difference?
a major issue down the
It
road.
had medial for the minor, but then for major it had both.
But, okay. But the main thing here too with the pec major and minor is look how that comes in. Your major's that top muscle, it's C5, C6, C7. Your minor is C8, T1. That just kind of is easy to line up to me, okay? Okay, your thoracodorsal comes off the posterior cord. Here it is. And that does your latissimus dorsi. And that's C6, 7, and 8.
How did you say that?
Latissimus dorsi,
No.
thoracodorsal.
That. Okay.
How would you say it, Paul?
Thoracocortisol.
Cortisol. Oh, dorsal?
Yeah.
Thoracordosal?
Thoracodorsal.
Oh, I think that's actually incorrect.
I figured it was. That's why I asked you.
That's a pretty safe guess.
If I
That
said
was
it,
probably
if
incorrect.
I said it, it's 75% chance of being incorrect.
Okay, okay. And then, let me find it. This is your lower subscapular nerve coming off of the posterior cord. Your upper subscapular nerve also comes off the posterior cord, it just comes off before the lower. And the upper does the subscapularis, and the lower does the teres major. So those are the ones that come off pretty close to the brachial plexus and does the shoulder muscles and your rhomboids and all those upper muscles up in here.
I have a question, like when we do quiz over this stuff, we're gonna have to know more than the nerve, we're gonna have to know if it comes off what cord and stuff.
As we go, we're gonna go up and down this thing when you know which way. Because what happens a lot of times in a brachial plexus injury, the damage will be at the cord area.
Where's,
Or it might be actually up in the trunk we're not gonna, I just want you to see the anterior and posterior division, but it's not, nothing's ever gonna come off of the anterior posterior division, you just need to understand.
And the divisions and cords, is it like that in your shoulder? Where's that
Yes,
at
and
in your
let me
shoulder?
show you how that kinda lays out.
Can you get Blake up there and mark on him? That's what Bill does.
I could,
Oh.
but I think,
That's what Bill does. He just gets those
he
sharp
marks
guys.
on him,
Yeah, marks on him.
that, see how that comes down into the shoulder? There it is.
Oh, I like that one.
Are we gonna get a copy
You
of
have
that one?
copies of
I
that
can
one?
give you a copy of that one, yeah, so I'll go do that.
I'd have Blake do it since he's gonna get marked on.
So, see, here's your upper trunk, here's your middle trunk, here's your lower trunk, and then you've got your divisions where these come anteriorly. And literally, the posterior division and the radial nerve is posterior. So what happens is this comes off and twists just a little bit. And that's why it's an as it comes down, it twists. You've got your anterior and your posterior. And then they come out and make the cords. So here's your lateral, medial, and posterior cord.
Like when you have thoracic outlet, what is getting impinged right there?
Actually, normally, it's more usually the subclavian vein, or artery that goes through this. And also, it can be, I think, it's normally right in here, because it's right in this area. So it actually, I think, can be any of that. I believe though, usually it's the posterior cord. Because normally they have weakness in the triceps, right? What did that lady have that day?
Him?
Or him?
It was in his biceps.
Okay, so that would be the upper, right? So that would be pressure on the lateral cord in the upper area. Okay?
Now, if it's in the scalings where it, I know where they
The
are.
same, see, the scalenes come right up in here, and sometimes they can just be laid out funny. You can also have vagus nerve issues if you have thoracodorsal, so you can have all those problems with, thoracic outlet syndrome.
Okay.
So you can have all those issues. I will get y'all a copy of that. Let me just go do that real quick.
Sorry,
and then you have it.
I got a black permanent marker, we can use that. They probably do.
See like one of the real white ones, that like get you high as soon as you take a cap.
Showed up at a bar one night, and I was dressed in blue and I was the only one in the whole bar. Always loved them.
Whatever you're supposed to bring me.
When are we gonna have a quiz on this?
Probably on Tuesday. Today's Thursday.
Are you gonna want us to know, a lot of these functional levels we do know, but there's some we don't, are we gonna need to know the functional levels?
Kind of, not so much. I'll try and separate spinal cord versus peripheral nerves, so probably on the testing and quizzes, there won't be so
We
much.
know triceps, but we didn't know that.
Only the ones I've given you before, how's that sound?
That sounds fantastic.
Okay. So we have all of those, so now we are ready to move into the axillary nerve. And we know that that's the C5, C6, and that it's the deltoids and teres minor. Let me put that up here for you. This picture, I think, came out of the old book, but again, I think the new book pictures are just as well. This is the back of the patient coming off C5, C6, and it comes down. This is where it innervates as your axillary nerve does, it innervates your deltoids, and then you've got your teres minor that's innervated right here too. The black on this is actually your motor innervations. As you get into the clear, that is your sensory innervations. We are not learning those. Remember, we're just doing sensory dermatome. So don't worry about the sensory nerve. If something says anterior cutaneous, subclavian, whatever, don't worry about that. Cutaneous means that that's a sensation, but as far as sensation, you're just learning dermatomes, and y'all know all those now, right? So so we're not doing the sensory nerves. I could make y'all memorize those, right? But I'm
Oh,
not.
that's okay.
All you're doing is motor.
Trust me, we've already reached the overload principle there.
Well, that's why we don't do that. They're not very, you use dermatome levels in the clinic. That's pretty much what people use. I don't. And of course, motor. So here's your axillary nerve. You guys look at your PowerPoint and let's read about that.
But you licked it.
Anything right.
Yeah. Cause okay. Some of the common injuries that occur with the axillary nerve, and you can see where it's at. So if you had any kind of, shoulder fractures, any of those things, common injuries with fractures of the humerus and dislocations of the humerus, improper use of crutches can cause issues. Remember, what would that be? Putting too much leaning into them. So it is your job now, because you know that, to make those kids stop it. Encourage them not to do that incorrectly, right? Your deltoids, what you see is atrophy with severe weakness in abduction, flexion, and extension of the glenohumeral joint. Teres minor is no major change in function, because your infraspinatus muscle will take over with external rotation, but you are going to lose some of your stability in your rotator cuff, right? So that's what happens there. Any questions on the axillary nerve? Deltoids and teres minor, C5 and C6. Okay, the next one is your musculocutaneous nerve, and it comes off the lateral cord right here. You can see it come off. Remember that your musculocutaneous nerve is a C5, C6, and that's basically your elbow flexors, right? So that would be your biceps and your coracobrachialis and the brachial.
Now that has listed C5, C6, and C7
Where does it have listed?
Oh,
on
it has right
this,
there.
on the brachial plexus picture that we passed around.
Mark that C7 on, it's C5, C6. Did I put that on there, or is it just one that you have?
It's just on the sheet that you copied earlier. You didn't.
Okay, yeah, put C5, C6 on that. You're gonna show me how to do it. So here is the musculocutaneous nerve coming down. Again, if you'll look at the C5, C6, it comes down and it innervates the coracobrachialis, the biceps brachii, and then the brachialis. And remember that the black is your motor function. Again, it goes on down and innervates some of your sensory stuff, but we're not looking at that, right? But just so that doesn't throw you. Pretty much your motor function will stop at your brachialis and in that elbow flexion area.
You get it? Now I can take it off, 'cause I just had to have you see it. Oh,
Because I didn't.
I won't say it.
So what are you gonna lose if the musculocutaneous nerve is damaged?
If you what?
What do you lose if the musculocutaneous nerve is damaged? Elbow flexion, right?
Your supination might be a little weaker too.
Yeah, it would be. You lose, because the biceps is a major supinator. your cutaneous nerve, dislocation of the humerus, any kind of open wounds like a stab wound or something like that. And then there's also trouble sometimes with entrapment of the coracobrachialis, but that's not a humongous loss, except you're gonna have some pain probably with entrapment, right? So sometimes it will get caught into that coracobrachialis muscle. Effects of injury is paralysis of biceps brachii and brachialis muscles, results in weak elbow flexion, weakness and supination secondary to the loss of the biceps brachii. And paralysis of the coracobrachialis muscles does not noticeably affect function. It would affect stability if you're a bodybuilder, right? But again, some of your stuff is your biceps kind of takes over with that and takes care of it. Any questions on the musculocutaneous nerve? It does come off of the lateral cord. It is a C5, C6 muscle. Okay, can you see it coming off there? Okay, your radial nerve, the posterior cord actually just turns into the radial nerve, okay? So the radial nerve's a real important little nerve there. They're all important. What you're wanting to look at is see how that comes down. Look at how that arm is turned. C5, C6, C7, so it comes off of the upper trunk and lower trunk and goes into the posterior cord. And what I want you to realize is see how this arm is turned? The radial nerve gets a lot of damage because of the way we function like this, right? But if you walked around like this all the time, you probably wouldn't damage it. So as it comes around this area, sometimes it has a lot of damage. So here it comes around, twist. This is the humeral. Oh, maybe it's on here. It's C6, C7, C8, T1. Triceps, anconeus, brachioradialis, supinator, wrist extensors, finger and thumb extensors. So again, you're looking at the posterior cord being a lot of extensor muscles. Common injuries, this is where you get the Saturday night palsies, where these guys lay on their arms like this, and result in denervation of those triceps muscles, so they lose their triceps if it's, they don't always lose triceps, that's wrong. Normally Saturday night palsy is from the elbow down. Your triceps come off so high, off of see where your innervation is of your triceps up here, and normally the problem with that Saturday night palsy is where this comes around. So a lot of your triceps normally are fine. It's from the elbow down that you'll lose your extensors if you have the Saturday night palsy.
So we need to lose that out, temporarily?
Yeah, you'd be like
It
that.
depends on how long they've laid there. I think I told y'all about I worked with a man and a woman one summer, and they were almost there at the same time. She actually lost her arm because she had laid on it for so long, they had to amputate above the elbow. And that was a circulatory problem, not a nerve problem. And then I had a man that same summer, and he had laid on it, but he got full return of the movement. But it was, we had to really work at it and build it back up. It's where they lay, it's like the arm up underneath them like this, and it can be vascular or it can be a nerve thing. So remember, if you've got really drunk friends and or if you deal with a true alcoholic that does the weekend
Roll them every
thing,
few hours.
yeah, you want them laid out when they're asleep. You need to roll them every 2 hours because they really do not wake up. It's like they're in a coma.
I had a friend that was drunk and he kept trying to ride his cot like a cowboy.
That's not when he's in trouble. It's when he's passed out that becomes a problem.
So she literally had to have her forearm amputated?
Yeah,
because
she
got
had laid on it for so long that it killed, there was no circulation.
You might have a drinking problem.
Yeah. Humeral fractures is some common injuries. Inappropriate use of crutches, again, can cause problems. Trauma, very vulnerable to trauma because it runs superficially and lies against the rigid CL groove of the humerus. Did y'all learn where the rigid CL groove was? I think normally it's just a groove and it's just right in this area. There's just a little groove to show how it goes. Shoulder dislocations, of course, can cause problems with it. Humeral fractures, radial neck fractures, also cause problems. And very vulnerable to gunshot and stab wounds because it's fairly superficial. Especially right in this area, it's superficial. So look how it comes down and innervates all those extensors. Remember where your extensors are. They're here in your forearm, so you can kind of see that. Your finger extensors are also in your forearm, right? Your thumb extensors, all of that is innervated by the radial nerve. Effects of injury depends on the site of the lesion and severity. Again, a lot of times the triceps are not affected. A lot of times it'll happen lower than where the triceps come off. Inability to extend the MCP joints, the wrist and thumb. So the common thing that goes with this is the drop wrist. So that's a term that goes with the radial nerve. So they have to have a splint normally, because remember, you can't function like this, right? So we went and saw a lady the other day, and she's learning to get some wrist extension, but most of her function is like this. So she actually would profit from probably having some wrist extension splints. Inability to supinate completely, weakness in elbow flexion, secondary to paralysis of the brachioradialis, and weakness of palmar abduction of the thumb. So abduction and extension of the thumb is part of the radial nerve problem. Any questions on that? Okay, the next one that we're going to look at is the median nerve. And your median nerve comes out, your lateral cord and your medial cord make up the median nerve. So it comes out through here and here, so it basically has nerve roots from every part of the brachial plexus. So it would be C6, well not C5, C6, C7, C8, T1.
Yeah, it's got C5 on there for that too.
Well, I don't think it affects function very
See,
much.
it
It
has-
may have some,
It had C5 for the radial also.
it's all right.
We'll mark it off.
But you're gonna go for me, right?
Yes, ma'am.
What it is it actually has some C5 fibers, but you don't see anything in the muscle when it's damaged. Those C5 muscles, you don't see anything in there. Because almost all your triceps are C7, that kind of stuff all the way down is a little lower. Okay, so here is your median nerve. And basically, it, turn like this. If you'll look where it's at the elbow, it's more on the front part of the elbow, right? Comes down, goes to the thumb and the first two fingers. So this is your median nerve function, right? So it's very important that we don't lose this. What's the main thing that affects the median nerve in the hand? What problem? Carpal tunnel. So that's very much a very functional movement. You do lose your pronators. So your supinators are radial nerve, your pronators in your elbow are median nerve. You lose the lateral half, so like this, your lateral half of your flexion, right? So remember, this is talking about the anatomical position. So lateral half would be of your flexor digitorum profundus, and then you lose wrist and finger flexors on the radial side. You lose the first and second lumbricals, okay? So you lose your first and second lumbricals. Your ulnar nerve does the third and fourth lumbricals. And then you learn, that's where we're at. First and second lumbricals, and then most of your thumb muscles, inflection and opposition and all of that is median nerve. So that's kind of how you can do. Okay? Common injuries, entrapment of the median nerve can occur at many points of the nerve, often accompanied by entrapment of the ulnar nerve. So remember, with carpal tunnel, you can also have ulnar nerve involvement, because that was actually a licensure exam question years ago. Haven't been on there recently, I guess. Thoracic outlet syndrome can cause lots of problems. Pronator teres syndrome is when you have compression as it goes through that pronator teres, and it's just some compression of the nerve. carpal tunnel syndrome, entrapment beneath the ligamentous band, and then humeral fractures and lacerations of the wrist and carpal bone injuries can all cause median nerve problems. Any questions on that? Effects of injury depends on the site and severity of it. Motor effects possible loss of opposition of the thumb, loss of ability to make a fist, atrophy of the thenar eminence. That is this area right here. This is the thenar eminence. Y'all found out? Y'all didn't know that before?
Not until we seen it on the test.
That's good. You were gonna have it today, see? As a result of atrium and paralysis, the hand flattens. And so it's called the APAM with the median nerve. And what they do is it's like this. This is the function they have. Those fingers rest in flexion usually, but they're very skinny because they've lost a lot of the lumbricals are a big part of this muscle bulk in here. So they've lost that. They've lost all their flexion in this front of the hand. So they can work these last two fingers. So actually this is kind of what it looks like. I'm sorry, I was confusing to
Cause
you.
it'd be
Because
extended.
they can
wouldn't
do the third and fourth, but these just kind of, so this is the ape hand. It's when the median nerve is damaged. And have you ever seen an ape hand, you know, it looks like they have two toes, like,
it? Not know.
yeah, those little guys, go to the monkey.
I would call it the stick 'em up.
Okay, that's the ape hand.
Yeah, we heard this coming, so we shut the door.
I figured.
Okay, so, loss of opposition of the thumb, we did this, and so it is the APAN, the median nerve. So you have drop wrist for the radial nerve, and you've got, the APAN for the median nerve, okay?
Well, Abe's still about that.
They're okay with it.
I'm going home and watch a
I think we
video.
give a little bit too much, attention to animals and their feelings
I don't know.
here lately in our
The
society.
caveman didn't like that commercial.
Okay, the ulnar nerve comes off of the medial cord. And here it is right here. So it comes off the medial cord. It is C8T1, so it only has fibers that come from C8T1 on the ulnar nerve. Here are how that comes down. You can see that. It is your funny bone nerve. So when you have a funny bone issue, or that's what you're hitting, it's right in between there. So that's your ulnar nerve.
Yep, Bill's made us twang it.
Yeah, well, you know, it's very superficial and damaged a lot at the elbow and all kinds of elbow injuries. When you go to sleep on it at night or whatever, your fingers go to sleep, that's your ulnar nerve. A lot of times if you get used to sitting in a chair with armrest and it doesn't have a good support there, your fingers will start going to sleep. So if all of a sudden your little fingers and, you know, half your ring finger and your little finger goes to sleep, somewhere you're putting pressure on that ulnar nerve. And normally it's at the elbow most of the time is what I have found. And it goes on down. The ulnar nerve does the flexor carpi ulnaris, so it does flexion of the fourth finger and the little finger. Medial half of the flexor digitorum profundus. It does all your interossei and the third and fourth lumbricals, okay? C8T1, ulnar nerve. Common injuries can be entrapped and damaged at many points. It is entrapped with the median nerve. Thoracic outlet syndromes can be a problem in inappropriate use of crutches, funny bone injuries, which would be injuries at the elbow. Effects of injuries is the claw hand. So what that is the first and set, these all work normally, right? First flank is in hyperextension in fingers 4 and 5, and the distal two are flexed, so it looks like this, because they're using this. But the distal two are flexed.
Is that what we learned in the pathology that they used yesterday? It was called like the detrans contracture or something.
That's where those are contracted, so yes, yes. And that doesn't normally happen in this problem. It's more, I mean, they can keep working that range of motion. That's more like with rheumatoid arthritis, that kind of thing. Loss of interosseous lumbricals 4 and 5, deviation of the wrist to the radial side. So they literally have some deviation and they function like this. Okay, I can't hardly make my fingers do that. But that is the claw hand. So radial is drop wrist, median is ape hand, ulnar nerve is claw hand. Okay. I want to look at one more picture here so y'all can get another view of
Not
this.
much to it.
Now, are we having a quiz or a test?
Yeah, today.
A quiz today? No, I mean, on Tuesday.
We will have a quiz on Tuesday. You aren't ready for the test.
Yeah.
Hey, Bill, or Jim, is that a light beer or is it full flavor?
Do I look like I drink anything like that? Eat anything like that? This is one of my beers that I make.
This is kind of a neat picture because as that brachial plexus comes down, you can literally see the lateral pectoral nerve. You can see the medial pectoral nerve coming in and do the pec muscles. The long thoracic goes right down this way and goes to the serratus anterior, which you can see how that comes down and innervates that. Remember, that's my favorite muscle. And what's its function? What does it do?
I thought sartorius was your favorite muscle.
No, my favorite is serratus anterior. I just think it's the prettiest little muscle around the rib.
Upward rotation and.
It does.
Protraction.
Yeah, protraction. So anyway, there's your long thoracic into that, your musculocutaneous, how it comes down, and does it right there. Here's your median nerve. Remember, it comes right down the front of the arm. Here it is, going into the thumb and the first two fingers. And then your radial nerve you can see back behind. And then the ulnar nerve is coming down here. So after it makes those divisions, it comes down and goes behind the elbow and comes down to these last two fingers. So there's all kinds of pictures on the internet that y'all can, this is an old picture, but anyway, just to kind of get a feel, because if you'll follow those nerves down, it'll help you see how those muscles are innervated.
So, what's the chance of us getting a copy of that?
I can
Bill's-
give you a copy.
hey,
It's
I'd love to
easy.
have a copy of that.
Bill's book on page 66 and 67 shows good pictures.
Okay.
Jim,
Okay.
Huh?
Bill's book on page 66, 67's got a good picture.
Okay.
For like the muscle cutaneous to the ulnar nerve. It shows every muscle that innervates and where it at. 66, 67, it shows the muscles where it innervates it at on the.
Okay, what I have done for you is I pulled up another little questionnaire for the cervical and brachial plexus like we did for the lumbar plexus to help you pull this together. So really look at these questions and kind of, so you can work on these together today. And we are quizzing on Thursday over this. And we will do, Tuesday, I'm sorry, Tuesday. And we are, we'll have, Jeopardy. So we'll do Jeopardy. Before the quiz or after? After. We'll do Jeopardy after the quiz. We'll do the quiz first. We're having a quiz on, we probably won't test Thursday, but we'll test the next Tuesday. What do y'all have for test next week?
We got a huge test on Monday.
Monday, we got the apocalypse.
Yeah.
The apocalypse?
So we gotta spend all weekend studying on that, and then part.
It's Jim's I'm Still the Man test.
Okay, I'm gonna go make a copy. Y'all work on those. Do you have any questions? What?
How many of them y'all have left?
No,
There's questions on
You're
the
supposed to
back.
go to that, we'll,
We need to
uh,
Questions on the back.
you can come in and do it.
One, please, one. I would need one.
You guys who are going to Mercy need to check, have they said anything about, you know what, I think in some of the other areas, you guys don't get on the computer. So she just requested that you be put on that, so I'm not gonna, there's one more session to go on the computer, besides that, because she thought you were doing it early, but I said she needs to get it done, because we're gonna be in finals on the